whole world shut down, ICUs lit up, and this is where the battle began. And critical care department becomes a battlefield. Initially, we were behind the curtains, but in the COVID, we were the front runners. And initially, everyone thought of the machines, maybe the ventilator, but what mattered was a man or woman behind the machine.
Meet Dr. Bharat Jagiasi. He is a distinguished leader in critical care medicine and director of critical care at Kokilaben Dhirubhai Ambani Hospital in Navi Mumbai. Beyond patient care, Dr. Bharat is an acclaimed author, prolific researcher, and honorary fellow of the Indian Society of Critical Care Medicine. As secretary of ICCM Mumbai and treasurer at the national level, he drives advancements in ARDS, mechanical ventilation, sepsis, CRRT, ECMO, and much more.
So it's a body who responds pretty differently to the certain illness rather than disease causing a major issue. Every body is different. So our response to the disease is more of a problem rather than a disease making us sicker. And there's something called as brain dead organ donation. So one brain dead donor can donate heart, lungs, 2 kidneys, liver. So too much of a benefit for the others. I mean, you can save so many other lives, or you can make other lives so comfortable. So I would say what gives us happiness is not about whether you won the war or not. How caring you when you're looking after your patient, that is what is more important. The happiest moments are when we did not win the war, patient didn't do well, but still family comes to you with a folded hand and say thank you very much, you did everything for the relative.
Hi everyone, welcome to Talking Through. My name is Rahul, and today I am really delighted and feeling honored to welcome our today's guest, Dr. Bharat. Thank you so much for taking time out for this particular podcast. I really appreciate. And before we formally start this podcast, I request you if you can share some more details about your professional experience and how and when you have decided to pursue your future in this particular critical domain.
So thank you, Rahul. Thank you for the invitation and doing this with us. So as you introduced me, I'm Dr. Bharat Jagiasi. I'm a critical care specialist, and as of now, I work for Kokilaben Hospital, Navi Mumbai, and I'm working as a director of critical care. Of course, there's a society called as Indian Society of Critical Care Medicine. So in India, that is the society which started the formal education of critical care, and we all are part of it. So I am being the past general secretary of the same society as well.
Indian Society of Critical Care
Indian
Medicine.
Society of Critical Care Medicine. It's known as ICCM.
Mm-hmm. And after pursuing your medical education, MBBS, when and how you got interest in this particular field, sir?
So critical care, I would say, rather than I choosing a critical care chose me. The reason being is, of course, my father is a doctor and my grandfather was a doctor as well, though my father doesn't practice anymore these days. So it was a notion, doctor ka beta doctor banega, engineer in those days. So there was always a pressure on me to be a doctor because I belong to a doctor family. And of course, I would like to break that now. I am not allowing my son to become a doctor. So in that notion, I, of course, appeared for the exam and scored decently and got admitted to MBBS, and I finished my MBBS. But if you realize MBBS, as of now, you get the degree of doctorate, you become a doctor, but eventually you're not a specialist, which is what is required these days. So no one likes to stop it over there. So eventually, initially I thought of becoming a surgeon because then we always thought ROI is better being a surgeon. And when I started studying for the entrance exam for the post-graduation, that is where I started liking medicine. I realized I'm more towards the medicine. So of course, when the result came in, I did not get a admission to surgery nor into the medicine because those are top-notch branches to enter in. And what I could get was into the anesthesia. I got anesthesia into the Grand Medical College, Mumbai, which is one of the reputed colleges. So many of the seniors around told me with the anesthesia being a background, it's a good branch to be because I wanted to be a surgeon, then a medicine guy. So it's somewhere in the between. You work with the surgeon, but actually what you practice is the medicine. And also there was a notion after anesthesia, you can do a super specialty into the critical care as well. So this is how I entered anesthesia. But as I started progressing towards anesthesia, my training progressed in anesthesia, I was drawn towards the critical care because in anesthesia also you have to handle a surgical critical care department. And this is why how my interest in critical care became a love for critical care and eventually got passion for the critical care. And formally out of the college, I never practiced anesthesia. Then immediately I joined the critical care, and this is why I became the critical care specialist.
And for general public's awareness and knowledge enhancement, may I ask you what exactly is critical care, emergency care, or intensive medicine? Because for a layman term, it's for us it's ICU, right?
Yes.
But in medical terms, what exactly is critical care?
So for general public to start with, they have to differentiate between surgeon and the medicine doctor. So surgeon is someone who does the surgery, and the medicine doctor is someone who looks into the physiology and treats you medically. So there are certain diseases which are to be treated medically, and there are certain diseases which are to be treated surgically. This notion is very important because we have seen this overlapping at the highest level as well. Someone who's got a medical disease, because some surgeon is famous, people tend to go towards that surgeon and take his opinion. Even in the major departments in the machinery of the system also, we have seen decisions of the medicine were taken from the surgeons and decisions of surgeons were taken from the medicine guy. So we need to understand the difference very specifically. If you have got a medical disease, you should consult a medical physician, and if you got a surgical disease, you should consult a surgeon. So this is very important for the normal public to know. Even though the surgeon is very famous, he cannot treat a medical disease, and same other way around. Even the medical guy physician is a very famous physician, he cannot treat you surgically because we are not entitled to do that. We are not trained that way. So there's nothing wrong in saying, of course, I cannot do the surgery, and same is true with the surgeon saying, I cannot do a practice medicine. So then this is the notion, and of course there's a super specialty beyond that. So once you become a surgeon, so these days they become the thoracic surgeon, bypass surgeon, cardiac surgeon. Then there's a colorectal, that is intestinal surgeon, a neurosurgeon, brain surgery. So there's a niche super specialty. Same is true with the medicine. Once you're into medicine, then you can do the super specialty. So critical care is one part of the medicine which can go ahead with the super specialty. Also, the pulmonologist, anesthesiologist, all these fraternities also can become a critical care specialist. They have that option open, windows open for all three. And only medicine guy can become also a gastroenterologist, cardiologist. So this is how the term. So you have to do MBBS. Then post MBBS, either you do a pulmonology or anesthesiology or internal medicine. And all these branches have the critical care as an option when they go for the super specialty.
And if I get to know about a day in a critical care specialist life from start to morning, what's your daily routine look like?
So one thing I must tell you, Rahul, when it comes to critical care, it's not a routine day. So always the day is different. So, and that's an advantage as well. This is why I love critical care. So I'll tell you, maybe one day I will enter the ICU thinking about I'm managing 4 or 5 patients who are not doing well. There's an emergency also which I'm handling, and this is what the general public think of. But there would be a day when I'll be just talking to a family who is fearful because not being informed well. So we are counseling them. So on that day, more than my clinical judgment, what is coming in picture is emotional intelligence, empathy, clarity in the talk is what is important. And one day I would be doing admin jobs. I'll be making the protocols, standardizing it, doing the audits, whether those protocols are working well or not. And of course, then the mentoring the junior doctors, nurses, and also we have the varied scenario. So it depends what day comes in. Some days stable patients are doing well. I have a time. I'll pitch into something else, or maybe some relative comes in, family comes in who wants to know about their patient. Then maybe we sit down with them for an hour or so, and my time goes that way. So there's no routine call. It's too much of a thing. So of course ICU is chaotic, but I would say it's a structured chaos.
Correct. I can understand the critical aspect of this particular specialty, wherein you always have to prepare for challenges. It's not like a routine day wherein everything is set.
Yes, never can be a planned day.
Understood. Right. And since you are into this particular domain from working from past 18-20 years, how you have seen the evolution of critical care and emergency medicine in India in terms of like its infrastructure and advancement in the technology, and especially after the COVID, what shift you have seen in India?
So first I'll talk about the advancement in India. So of course, critical care has come long way, and here I would like to specially mention about the Indian Society of Critical Care Medicine, because initially few of our teachers, they were the founder members of the society, and they were trained abroad in the West, and they came in over here. So they thought of starting a critical care training formally. So we were the first, that is Indian Society of Critical Care Medicine was the first institute to start a critical care fellowship program formally. So, and those were the seniors who were talking to the government, MCI, then now it's an MC to start the super specialization in the critical care. But it took them almost 10 to 15 years to convince them, and till then we build up. So when I did my Indian Diploma in Critical Medicine, it is by the ICCM. And then we didn't have the DRNBs or the DM, which is started now recently last few years. So government of India realized little late, but those are the one which started, and because of that initiative we did so well in the COVID. Because it was, if not for them, we wouldn't have so many critical specialists in India, because the formal training by the NMC started a little later. It was for them who initiated, who thought about this. There were so many critical care specialists who were there in India to save their lives. Now you talk about the COVID, I would say, of course, COVID was a stress test for the healthcare workers, and critical care people were the frontliners. But whole world shut down, ICUs lit up, and this is where the battle began. And critical care department becomes a battlefield for the people to nourish, and eventually the critical care specialists were revealed because of that. So initially we were behind the curtains. We do existed. We were behind the curtains. When it comes to the normal public, they didn't know much about the critical care specialty. But in the COVID, we were the frontrunners, and initially everyone thought of the machines, maybe the ventilator will come in, it will save the life, oxygen will. But what mattered was a man or woman behind the machine. And that is what the critical care specialist behind the ventilator is what mattered. And this is what eventually the public realized. And this is why I think one of the reason I'm sitting here in front of you, because you also have realized the importance of the critical care specialist over here. So of course, COVID revealed us.
Right. And I really admire and see the foresightedness of the society, Indian Society of Critical Medicine. They were ahead of time in terms of understanding the importance of this particular field and prepare the medicos and the overall infrastructure, and also pitching in government, right, in terms of making our infrastructure more robust. And in line to this question, I just want to understand, God forbid, if in India or across the globe, if any other situation like COVID comes in the future, how well prepared we are as compared to like 5 years back.
So of course we are prepared, but preparedness is always a moving target. It's never a one thing. It's always a dynamic thing. As we go ahead, preparedness, the targets keep changing. And so we are very well prepared as of now. We have good infrastructure in place, but of course we have to still train our doctors. And what I required is we have to have now simulation based training for the junior doctors and the nurses around. So we have to build a good simulation center so that we are not taken by surprise. We already have worked in those scenarios and we can practice it very well, because it took us 2-3 months to get into the picture. But if we have the simulation based training with the varied scenarios, it will really work very well. So what is required in today's era, I would say, is the requirement is of the simulation labs, which will have those scenarios, and eventually it will help all the junior doctors and nursing who are going to be the future of the critical care.
Briefly talked about advancement of technology in this field. In your last 2-3 years of experience, and considering the future, you must be in touch with various medicos across the globe. You have published multiple research papers. So I'm sure you are exposed to where the future is going in this particular field. Can you share your personal experience with the advancement of technology? You and your colleagues are able to treat some critical ill patients, and where the future is going.
So yeah, innovation is working well, and we call technology as a new stethoscope. It's not going to replace the stethoscope, but of course it's a new thing which is available. It will augment the care, but it cannot provide the compassion to the patient. So it's not going to replace the human beings. Technology is here to remind us and let us know we need to be better, because it's a mirror to me to let me know, okay, I can be much better than this because I'm competing with the technology. but at the same moment, I have to realize it will not replace me. Code and compassion have to coexist. They have to work in tandem, and it's an integrated one. So in ICU, the technology is changing the care in ICU, but we also need to be changing along with it. We cannot be just sitting idle and watching it. So as technology changing the ICU care, we have to change and adopt it so that we both coexist and work in tandem for the betterment of the patients.
Exactly, completely agreed, sir. And the next point is related to understanding the psyche of patients, caregivers, and family and friends of the people who are admitted in ICU. I know whenever someone is ill and doctor suggests that this person needs to go to an ICU, family always have a concern: is that really necessary? So in such situations, how you explain the criticality of the situation to patients, and in what cases ICU admission is really important?
No, that's a very good question, and this is why I love the critical care, and we always speak of this in critical care because this is where the critical care stands apart from the other specialties. Because here we not only emphasize the clinical judgment, we also value the emotional intelligence equally as good as the clinical judgment. So critical care specialist needs to be emotionally intelligent as well. EQ needs to be emotional quotient needs to be pretty high. So as you said, family needs to be counseled. So the clarity of the thoughts, openness of what is required in that case, why the patient is being wheeled into the critical care. So the various options: either the patient is critical, requires a critical care monitoring, or maybe requires an aggressive treatment. So or maybe requires an aggressive investigation. So those are the various reasons. So you find out what exactly the reason is, what has happened, what are the implications both ways. If good happens, how the course would be. If the bad happens, what the course would be. You speak to the patient in an open mind, because eventually it's not in your control. In critical care, control is a delusion. So you have to speak openly with the patient what has happened, what could be the progress either ways. And if you speak that way with that clarity, I think everyone believes you, trust you, and that gaps gets resolved and they start believing you.
Correct. And our next leading question is related to in what all medical conditions ICU admission is really important. I know some of the things, like if somebody is going through any organ transplant, pre and post op, they need to be in the ICU, or any like severe accident, brain hemorrhages, these sort of things. Apart from that, in your experience?
So even that is not necessary. So
Mhm.
many of the transplants, if they do well, maybe there are certain hospital setups where the transplant is very routine for them. It's a daily thing. They don't admit the routine transplant patient to the ICU.
Right.
So when the patient goes to the critical care unit, you, as I told you, there are various criteria. Or the patient is critically ill in the sense vital parameters, heart rate, blood pressure, the rhythm of the heart are not good. So that needs a correction, that needs a monitoring, that needs a medicine treatment or surgical treatment for that patient goes down.
Understood.
Sometimes monitor those parameters are good, but you need an aggressive therapy for it. Patient needs lots of fluid challenges. Maybe patient needs certain electrolyte imbalances. They would needs to be corrected immediately before the rhythm changes occurs. So for those reasons also sometimes patient lands up into the critical care, and many a times they just the aggressive tracing hourly lab and see how the trajectory is, how the response to the treatment is. For those reasons patient lands up to do. So any of the cases, even the, for example, you said brain hemorrhage patient, if the brain hemorrhage is very trivial, patient is conscious, oriented, that patient will move to the ward with the close observation. If the patient has a brain hemorrhage and patient's conscious level is down, I feel this patient is becoming more drowsier and drowsier over a period of 15 or 20 minutes, whatever, that patient will end up into the critical care. So it's not the particular condition, it's how the patient has responded, or the severity of that condition will allow the patient to land up into the critical care.
Correct, correct. And one thing which I personally experienced, and I have seen some near and dear ones going on ventilator care, right? But whenever any patient's family member, they hear this thought from the doctor that there is a need to put that patient on ventilator, they always raise a concern. So in what all cases putting ventilator will be beneficial, and again, how do you tackle such situations? Again, patient counseling.
So yeah, this is a common myth. Many believes ventilator means death. Actually, it's not that way. So ventilator is used for various ways. Most of the time, it's just uh, used for so either the primary organ is not well, that is lungs is not doing well, or maybe the respiratory muscles are not good enough, and ventilator is being used for that purpose. There's some illness which has caused a secondary organ damage, and ventilator is being used for the other purpose. And maybe in the simplest of the things, prolonged surgeries, post surgeries, longer duration of surgery was the patient needs a reversal of the muscle relaxants what were used, or the sedation what were used, then anesthesia what was used during those prolonged hours of the surgery. Also the uh, little parameters like blood pressure is on the lower side because the fluid resuscitation needs to be done. So there are many technicalities reason for the various reason ventilator is being used. And if you see, the overall mortality on the ventilator varies from around 30% to 5% depending on the condition and the hospital or the care where the patient is. So if even if I take the worst, 70% of the patient survives off the ventilator. It's a 30% of the case which goes. That is the worst figures I am taking into account, which is also not true in the better setups. So ventilator doesn't mean death. And if it's a terminal illness, for that reason patient is on ventilator, of course my results might not be good. If it's a primary illness, for example, patient had dengue or patient had malaria, which is being treated well, now the secondary organ damage as well. So usually those conditions have a better outcome. 50 to 60% of them do well. Same was with the COVID. Yes. So in certain cases, patient did not even realize they have a COVID, and there were certain number of patients who really went on the ventilator and didn't do well. So it's a body who responds pretty differently to the certain illness rather than disease causing a major issue. So our every host, every body is different. So our response to the disease is more of a problem rather than disease making us sicker. And in that way, a ventilator works well in many of the situations than not. So it's a support system which has been given till the main disease process is reversed, and once the disease process is reversed, that support system comes out.
Understood. Right. And before this podcast, when we were having the informal discussion, you have mentioned the term dying with dignity, right? So I like to understand this particular concept, especially for elderly people or maybe for critically ill, last stage patients. What exactly is dying with dignity, and how you deal and explain this situation?
So dying with dignity is actually a call which we need to understand, and it's very difficult in India because Indian population being a very emotional population and emotional quotient being very high, it's very difficult to practice. But I take onus on us. It's a responsibility to let the relatives know what we are facing through. So supposedly, as I spoke about, there's an elderly patient. For example, he's got a carcinoma, and there's a multiple metastasis all across it, and he's underwent many surgeries and many chemotherapies, but eventually that's not working well, and now that patient has become breathless. So as a family, we want to do everything for him. I would like to put that patient on the ventilator. I would like to continue with the antibiotics, but at some stage we have to realize we have to call it off. I mean, as I told you, control is a delusion. Everything is not in our control. So we have to realize that, and we have to make our relatives understand, okay, this is the end of it. Or maybe a simple disease. Suppose there are certain diseases, there's something called as a chronic obstructive disease of the lungs or the interstitial lung disease. So they progress as the time goes on. In the end, lung is so fibrotic, it's very difficult for them to breathe. Their oxygen dependence is so long. So when they come to ICU and they are breathless, putting them on ventilator is not really going to help much. Even if they survive that episode, eventually in few months time they will have 2-3 more
Quality of life.
admissions to end of. So those are the areas that we need to understand, and we also have to make family understand this. Okay, this is what it is, and now we should call it off and let that person die with dignity in presence of the family without pain, rather than going through so much of process and family not being around, which actually matters in the end.
Understood. Right. And Dr. Bharat, one point I like to understand, it's not typically associated with critical care exactly, but just for my understanding and for our audience knowledge, I like to know more about what is the current state of organ donation in India, how this overall ecosystem is working. And since you are very well connected with people across medical fraternity and from government as well, so your perspective on
So I'm not connected, but this organ donation comes to the critical care specialist.
Okay.
So because the reason being is there is live organ donation. So if someone kidney is not working or someone's liver is not working, so they have the legalities, a close relative will do the cross match and the donation will happen. And there's something called as brain dead organ donation. So supposedly someone's kidney or liver is not functioning and there's no close one in the relative who's willing to give, or maybe they're willing to give, there's not adequate match over there. So there are certain brainstem death, what we call it as a technically. So there are certain parameters what we look into, clinical science we look into, we do something called as apnea test for the patient. So once those are proven brain dead, and of course because it's such a critical patient, that patient lands up into critical care department. And this is why critical care specialists are very much associated with it and very much aware of that fact. And so identifying brain dead patient, counseling the relative, he's brain dead, now nothing is going to work. Of course, within all the parameters, there are technicalities into it. That's not an easy thing to do it. And then counseling the relatives, yeah, this patient is brain dead and he's now got an irreversible disease. And because it fits into the law, this patient can go for the organ donation and can give many life. So when I enumerate a number of lives, so one brain dead donor can donate heart, lungs, 2 kidneys, 2 different patients, liver. Again, sometimes liver can go half in 2 sections, but that's very rare. Then the pancreas, intestine, skin, bone tissues. So it's too much of a benefit for the others. I mean, you can save so many other lives, or you can make other lives so comfortable. Like recently we had one in our institute. Eventually even the arm was transplanted. The family was kind enough to do that. So the someone who did not have the arm, even that was transplanted. Now that guy is living with one healthy arm with it. So of course it's very disheartening for the other family who lost the closed one and the loved one. But at the same moment they were kind enough to allow that to happen, and 10 or 12 other families really are happy and do well. So this is what the organ donation is all about. It's not possible for everyone. So there are certain technicalities. So every dead cannot do that, though we are now also looking after the circulatory deaths as well, but those require the high-end setups and all. But everyone cannot be the brain dead. Someone who's not doing well, is into the palliative care, is into the end of life care, doesn't mean that's a brain dead patient. So brain dead patient is a specific thing, and then of course someone identifies it and correct it, then of course we should go for the organ donation in those cases.
Understood. Right. Thanks. And Dr. Bharat, in last few years, in your experience, have you seen any shift? I'm talking about some stats, because nowadays people are getting sick because of their lifestyle. Maybe they get admitted to hospital because of some accident, or maybe some drug reaction, antibiotic resistance. So basis on the stats and your experience, whatever patients are getting admitted to ICU, what is the percentage? For example, half of the patients are like maybe elderly patients or terminal ill patients, or you are looking at some new trend or shift, people getting into ICU. Is there something
So
new coming
usually
up?
Indian ICUs mainly in around the year are mostly, as you said, elderly patients. Those are turning out to be the geriatric ICUs because healthcare system is that robust. But of course, there's a surge of disease in different. Now this is a rainy season, so you would have more of malaria, dengue, landing up into complications, and trivially some other flu-like illnesses. Patient who already was some lung disease, they will land up into the ICU with those. And sometimes there's a surge of the heart attacks, so young heart attacks comes in. So it's a mix of all, but overall, as you asked me, it's more of a, if I have to take it round, average of the whole year, it will be more of the elderly patient, but it changes every time. It's a different surge altogether, and you don't know. Sometimes there's a surge of heart attack patients, sometimes there's a surge of medical illness patient, sometimes there's a surge of surgical patients as well. Patient undergo lots of major surgeries in certain period of time, especially in the vacation period. They plan it that way. So in that time, you have post-op patients who are landed up into ICU because the surgery was prolonged or it was a big surgery. So they are there for the ICU for the observation.
I can understand. So as a director of critical care, basis on like historical data or your experience, you plan accordingly, right, to cater the patient needs and
So we don't plan which patient is going to come in. That depends on the disease. But of course, the needs of the patients are planned in the cater. So any tertiary ICU will have all the facilities to cater any patient any moment of time.
Correct.
But saying so, though the innovation is happening, but the adoption of the innovation is not even. So in the metro cities, you have all the facilities. We spoke about innovations. We spoke about the artificial intelligence. We talk of transplant patient not being in the ICU going. So that all is possible in the metro. But when it comes to the tier 2, tier 3 cities, there are many other cities we are fighting for the basics of the critical care as well. So that adoption needs to be taken care of. So somewhere we also have to start with the digital training so that evenness comes in and digitally everyone is trained, and there's some sort of course there will always be a difference between 1 and 2, but we should not, there should not be a major vast difference. They should come at certain level altogether. So digital training is also is what very much important, and we should initiate that so that the cities which are struggling for the basics of the critical care should come and align with us.
Correct, correct. I completely agree. In Western countries, since past 20 years, like telemedicine and other technological advancement has happened. But in India, considering the vast geography, yes, if anything, which is if any senior person like you can guide some of the new medicos through a video conference, or maybe counsel some patients through video conference. If that ecosystem is there in the hospitals, I know we can do it by a phone, but there has to be like integrated system which is up to like approved by medical council or ethically right.
So as you talk of this, AI is playing a very good role in this. So
Mhm.
AI can flag the deterioration. AI helps in remote monitoring, which has broken down the geographical barriers. Also, predictive analytics will let me know the crash actually before it happens. So this is the overall scenario of something called as EICU. We'll talk of electronic ICU, distant ICUs. In the remote areas, there are institutes who all practices this. There are agencies who all practices this. So in the remote areas, in the primary or secondary healthcare, they uh, have those cameras in place. There's also a monitor in place, and actually those will be remotely monitored by someone else who's sitting maybe a 500 miles away or 1,000 miles away. So they pick up those points. They direct doctors around, nurses around. This is what is happening over there, because the monitor over there is indicated. I'm sitting some 1,000 kilometers away, so I can pick those areas. I can guide the treatment. So this is being practiced, but it has to be revolutionizing more. It has to come, it has to have more of the legal value also. The push has to come from the different areas so that it uniforms the critical care across the globe and across the nation.
Right. So, Dr. Bharat, one next question from my end is related to any sort of advice you like to give to young medical professionals who are looking to opt critical medicine in their super specialization. What kind of mindset they can come in?
So my advice to the young intensives would be, so initially, even for us when we were young, though I would say still I'm young, so it was the adrenaline rush what used to help us out. So it was more of the procedures in the critical care. It was more of a life and death situation. CPR, code blue calls is what used to help us and give us the adrenaline rush, and we used to enjoy that to start with. But the soul of critical care lies in consistency there. So what is important is hourly monitoring of the patient, and making subtle changes in the ventilator, in the support system, whatever is on, whether the disease is progressing or the regressing, and that is more required, and that is what gives us a better outcome than those the dramatic things. So the outcomes of critical care are better in consistency than being dramatic.
Correct, correct. And in your last 18, 20 years experience, can you share any critical, I would not say memorable case, but any critical case which you have solved successfully in terms of like reviving a very critically ill patient, and that has given you immense like happiness from like bottom of your heart, and you feel that the case you have solved is like one of the iconic cases, and any case which you have remembered for the life.
So when it comes to critical care, every case is like this. Very
Mhm.
frankly, Rahul, I don't think any critical care specialist will give you one case of that kind where the life has been saved, because our job is that way. So every day,
Yes.
someone who comes to us is critically ill, and we're gone beyond the situations where we use all the machineries, and many of the patients have done well, and there are few who have not done well as well. So I would say what gives us happiness is not about whether you won the war or not. How caring you were you when you're looking after your
Right.
patient? That is what is more important. So rather than the clinical judgment, ethical issues are more important over here. So we are happy, of course, when the life is won, when someone does well. More often, we always happy, and this is what our job is. But also, the happiest moments are when we did not win the war. Patient didn't do well, but still, family comes to you with a folded hand and say, "Thank you very much. You did everything for my the relative, and we are really satisfied the care kind of care which was given." So even that is very gratifying, and uh, uh, it's a very good feeling for all of us. So the cases infinite, but that is our job, so we don't take a pleasure out of it. We know this is what we are here for.
Right.
But when family talks about the care which was given as a human being, that is more gratifying to us.
Understood. Right. Right. And one personal question, Dr. Bharat. If not medicine, what any other profession you must have chosen after your like schooling?
So as I told you, Rahul, I belong to the doctor family, so I
Mhm.
never thought of it. So I am not sure about this, but now I know. Uh, since being in a critical care, you eventually deal with so much of death and life situation. Everyone becomes a philosopher in the end. So
Mhm.
now I know when I cut off from the critical care, I would like to spend more time with my family, with my kid. Maybe I'll have a coffee shop somewhere in the hills, and we'll be talking philosophy to the visitors over there.
Wow. Any life lesson you like to talk about, be it from any patient, their families, or any colleague, any professor? Uh,
So, life lesson, what we would say is, as I told you, control is a delusion.
Mhm.
This is what I've learned in the critical care. So, we always feel I'm in control. My patient's heart rate is good, blood pressure is good, my medicines are patient is responding very well to the whatever medicine we have started. But again, that's a delusion. Uh, one single report or just change in the rhythm will change your thought.
Correct.
Totally, the situation changes altogether. A patient which I thought of I'm in control is totally gone out of control and might not even do well. So we have to realize we are just here to provide the service. Control is not within us, control is there upstairs. He's
Right.
controlling everything, and we just have to stay humble, stay kind, and stay alert all the time. That's what the lesson
Exactly.
is.
And Dr. Saab, before we wrap up today's podcast, I request if you have any message for future generation of doctors, caregivers, or as a society as a whole, feel free to use this platform and impart your message for our audience.
So I would like to tell them, let your care be clinical, but heart be human. Though protocols are there in the ICU, they save lives, but also putting your hand on someone's shoulder calms them down. So empathy needs to be practiced pretty well. In the ICU, we may not always win, but we can always care. And every life we touch has also left a mark on us as well.
Dr. Bharat, thank you so much for this particular message for our audience. And from the bottom of my heart, I really like to sincerely thank you for taking time out for this podcast. I know the kind of knowledge and experience you have, 1 hour odd time is not enough to justify the kind of knowledge you have. But as we discussed, we really like to work with you. We really like to talk to you again in similar sort of podcast and want to do deep dive in certain topics which are really close to your heart. And as you mentioned, you feel that people should know about these things, right? So we definitely invite you in near future and talk on some different topics related to critical care and emergency medicine. Till then, thank you so much for your time.
Thank you, Raul. Thank you for having me over here. Thank you
Pleasure.
very much.